present here and welcome back to our favorite channel in understanding cancer, Cancer Reach. Cancer Reach is an initiative by our very own oncogenius, Dr. Krishnamani, who has started this channel in order to make patients and caregivers access the right treatment at the right time. Without much further ado, I will start with introducing our doctor. Dr. Krishnamani, a renowned medical oncologist, is having over 10 plus years of experience and he is associated with American Oncology Institute here in Hyderabad. He has extensive expertise in treating both solid and hematological malignancies. He has been actively involved in academic contributions and professional development. He has participated in numerous seminars and meetings, attended various workshops, and presented papers at various national and international scientific forums. He has continually expanded his knowledge and skills by completing fellowships from prestigious international institutions. Welcome to you, sir. Over to you, sir.
Hello, thank you so much. Welcome all to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And we are in the last week or 10 days of this year. So today's topic is all about recapitulating what has happened in oncology in 2024. Most likely, this will be our last live session for this year. So we wanted to just highlight what are the important things in cancer which has happened in the last 1 year in 2024, which has impacted the lives of our patients.
So, sir, starting with the most common cancer in women, that is breast cancer. Sir, if you could throw some light on how there have been advancements in 2024, especially in breast cancer, and also give us an idea about triple negative breast cancer.
As you know, we've already discussed that multiple times. Triple negative is a very bad variety of breast cancer. It is extremely aggressive, and there's a high chance of recurrence of triple negative breast cancer because triple negative means it is hormone negative, HER2 negative. There is no target to, like if you're hormone positive, you give you hormone therapy. If you're HER2 positive, you get trastuzumab or pertuzumab. But in triple negative, nothing will work for you except chemotherapy. So what people have done is, in the stage 4 triple negative, we use immunotherapy with chemotherapy now. In stage 2 and stage 3 also, people have started using immunotherapy in 2024 and the results of those studies have been excellent. So today, if you have stage 2, stage 3 breast cancer, you are advised chemotherapy plus immunotherapy. The name of the drug is pembrolizumab. Prior to surgery, this will go on for a period of almost 6 months. And then you are taken up for surgery and the immunotherapy is continued for another 6 months. So immunotherapy prior to surgery with chemotherapy and immunotherapy after surgery without chemotherapy. The name of the drug is pembrolizumab. And by adding this, you are achieving more pathological complete response. That is, when surgery is done and the tissue is taken to the lab, if no tumor is found, it means the patient has achieved pathological, that is when you cut the specimen, the pathologist says complete remission, that is complete response, no tumor is seen, not one cell is also seen. So pembrolizumab, when added to chemotherapy, is helping you achieve the PCR. Those who achieve PCR get better results later, their survival is longer. So in 2024, the game changer has been immunotherapy in stage 2, stage 3 triple negative breast cancer to increase PCR and overall survival. And the drug is, it doesn't have side effects like chemotherapy. Yes, it has immunotherapy related side effects, which are seen in 3 to 7% people. And from a financial point of view, the drug is in India, if you purchase 5 cycles, the rest 12 cycles for the whole year are free. So what was very expensive earlier, you used to pay for each cycle into 17 cycles. Now you pay for 5 cycles only and the rest 12 cycles are free. So if those 5 cycles we can afford, then I think immunotherapy should be part of the treatment regimen for early breast cancer, triple negative.
So, moving on from triple negative breast cancer, What about the HER2 positive breast cancers? Any advancements which have been made in that field?
So HER2 positive, you're asking, right?
Yes, sir.
HER2 positive, what has happened is so we know the drugs which are there, trastuzumab, pertuzumab, TDM1, TDX1. So this TDXD or NHER2, um, even from 2023 it was there, not that it came in 2024. But today, if you have metastatic HER2 positive breast cancer and you progress on trastuzumab, earlier we used to give TDM1. Okay. Now that's called Kadcyla. Now we give NHER2 or TDXD. It goes into the brain very well for those patients who have brain metastasis also. One more thing, TDXD has also been suggested in a variety of breast cancer called HER2 low breast cancer. HER2 positive we spoke. HER2 low means HER2 is not there much, 1 plus HER2 plus. Even in those patients, if they fail prior treatment, TDXD helps. So 15 years back, it was trastuzumab. Then pertuzumab was added. Then came Kadcyla or TDM1. Now the big boss is NHER2 or TDXD. But please understand, TDXD is after failure of trastuzumab in stage 4 or in HER2 low breast cancers.
Okay. Sir, any advancements which have happened in the field of genetics for cancer overall and also throwing a spotlight on the breast cancer?
A lot of things keep happening. Like you check up for new mutations like ESR1 mutations or PIK3 mutations in hormone positive. Not that it is specific for 2024, but in general. Then the BRCA1 and 2, and then PALB2 is a gene which we commonly see nowadays when we do a lot of genetic testing. NGS has picked up. We spoke about NGS last week. NGS is done in
Yes.
breast cancer too. So genetic part, but for an audience, what they should understand is when you talk about genetics in breast cancer, keep it very simple. BRCA1 and BRCA2 seen in 5 to 10% of patients, especially young patients, patients with a family history, patients with male breast cancer, those who have bilateral breast cancer, those who have ovarian cancer. All of them, please, and triple negative. Get your BRCA1 and 2. 5 to 10% patients will be positive. If you are positive, you're put on a drug called olaparib. And you're positive, your first degree relatives ought to be tested.
What have been the advancements in preoperative treatment on esophagus and gastric cancer, sir?
Yeah. So let us just go back looking at the history, the last 50 years, 60 years. So when somebody presented with esophagus or gastric cancer and it had not spread, by default, surgeon used to take it off. Now, preoperative therapy or neoadjuvant has come because if you give it before, you are able to downsize the tumor. You're reducing the size of the tumor. Surgery becomes easy. It's not a very extended surgery. So when surgery is easy, the patient recovers faster, hospital stay is less, blood loss is less, infection is less. Also, the reason for giving preoperative is on scan, you see disease here only and here in lymph nodes. But there could be micrometastatic disease which is not seen on. So when you give preoperative, it helps micrometastatic disease. Disease present here and there which is not visible on. And as we spoke, if you develop pathological complete response, that means you have developed PCR, your treatment has worked exceedingly well. This patient will do very, very well. So it helps you to decide which patient is doing well and will not require further treatment. If you don't achieve PCR, you will say your disease is resistant. The chemo or radiation given prior to surgery didn't work that much. So you need additional treatment because you will. So these are the reasons why we give preoperative. So now in stomach cancer, the standard of preoperative care is you give 4 cycles of chemotherapy called FLOT, FLOT. You do surgery and do 4 cycles of FLOT. Doing this, the survival increases, period. In esophagus tumors, you do radiation plus chemotherapy, then do surgery. By doing this, the survival increases. So esophagus, preoperative chemoradiation. Stomach, perioperative, peri means before and after surgery. Perioperative chemo, flot in between surgery. Now, in esophagus, people looked at chemo versus chemoradiation. Chemoradiation is standard of care. We say do chemoradiation, go for surgery. In 2024, there was a study where they did chemotherapy versus chemoradiation. The results were more or less same. More patients in chemotherapy arm defaulted further treatment because of side effects. So finally, they came to the conclusion that even in 2024, chemoradiation for esophagus prior to surgery is the standard of care.
Okay. So similarly, advancements with immunotherapy have been made in lung cancer as well.
Correct.
So can you throw light on that?
So again, giving you a brief history. So whenever a drug comes into the market, it usually is tested in the stage 4 setting, where it is hopeless situation, metastatic setting. Once it shows wonderful results there, you say, why not use it earlier so that patient doesn't go into stage 4? So that's why you have got this drug in the pre-surgical setting or pre-operative setting. So in lung cancers, which are non-metastatic, which are operable and surgically removable or resectable, you are going to give chemo plus immunotherapy followed by surgery. By doing this, your results are good. Same things what we discussed. So if patient is eligible for chemotherapy, finances are notwithstanding, no side effects regarding, no contraindications for chemotherapy, for immunotherapy. Immunotherapy is today added prior to surgery. And again, the name of the drug is pembrolizumab.
Sir, a lot of lung cancer patients also have brain metastasis.
Yes.
So how do you approach those patients? And also, does radiotherapy play a role in such cases?
So what we always tell our patients is, see, the brain is covered by something inside, by a blood-brain barrier, BBB. So God has made a covering which prevents anything from going into the brain. So that's why your chemo also doesn't go into the brain. So anything in the brain, any disease in the brain, the chemo will not go and act. So either you have to remove it surgically or you have to give radiation. Got it? Now, so when somebody has brain metastasis, earlier what we used to do is, if single brain metastasis or two brain metastasis, we used to say surgery, or we used to multiple brain metastasis, we used to say radiation. Now, we have discussed time and again in lung cancer, a variety called EGFR positive, ALK positive. In EGFR today, the right drug is osimertinib. In ALK, alectinib and lorlatinib. These are third generation drugs. We have discussed this earlier. This is like your iPhone also we have discussed, your latest iPhone. Third generation is better than first generation. iPhone 17 or 16 is better than iPhone 10 or 11. So the third generation drugs have advantage of crossing the blood-brain barrier. That means they go into the brain and they can reduce the disease in the brain. That means you can probably avoid radiation in those patients. Okay. So in whom are you going to use this? In all patients with lung cancer with brain metastasis? No. If I have little brain metastasis, I have no mass effect. That means no symptoms due to that, like headache, vomitings, double vision, fit, or weakness. Okay, so no mass effect, small volume, no big metastasis, less than 1 or 2 centimeters, no midline shift. The brain is compartmented into two halves. If the mets are here and it pushes to the other half, that is called midline shift. So no midline shift, no mass effect, a small volume disease, few lesions, asymptomatic patient, then what you will say is, see boss, you don't have any symptoms. You have little disease. It is not causing a lot of pressure in your brain. Avoid radiation now. Take osimertinib if you're EGFR positive. Take alectinib if you're ALK positive. My medicine goes into your brain via the blood-brain barrier and it will control your disease. Am I audible?
Yes, sir.
Yeah. So in those patients, you can avoid radiation. But please understand, if you have large brain mets causing midline shift, severe symptoms like headache, vomiting, weakness, in those patients, your drug will not be that effective because this patient will die maybe very soon. So we have to take action immediately. Okay. So today's newer molecules can go into the brain and reduce your disease in the brain, thereby either avoiding or postponing radiation, thus improving the quality of life of the patient.
And so this is same for all types of lung cancers, or is it specific to one population?
Yes, I spoke about EGFR ALK. Now, if you are EGFR ALK negative and all that, you need chemo. Chemo doesn't go into the brain. So then I have to give you radiation.
Okay.
I'll give you radiation and then start chemo. Only if you're EGFR ALK positive, and as I said, these criteria, you will take these medicines without radiation.
And so coming to the maintenance therapy in lung cancer, especially in small cell lung cancer, what are the advancements which have happened in 2024?
See, small cell, remember, very bad disease, seen only in smokers. Melts like ice, will come back the same way. It's only of two types, limited or extensive. Extensive, bad. Patients survive maximum 1 year, 1.5 years. Where we give immunotherapy with a drug called atezolizumab. Limited disease means it is limited to a particular area. You can give radiation and cover it. Despite doing all this circus of radiation and chemo, still patients go with extensive disease. That's why now in limited disease, after radiation and chemotherapy, if the disease responds, if you develop remission, we give a drug called durvalumab as maintenance for 2 years. This improves the survival. So in a very bad disease, which is seen exclusively in smokers, which usually is present in advanced stage, or the limited also gets into advanced stage after treatment also, maintenance immunotherapy is helping you push the disease further and improving the survival of patients.
Okay, sir. And sir, we believe that there have been some advancements which have been made in cervical cancer as well. So can you start right from the beginning for cervical cancer, especially covering the genetics as well as the induction chemotherapy for cervix cancer in patients?
See, cervical cancer, understand one thing. I would like to keep reiterating it. It's the second most common cancer in women. We have to prevent it. It is caused by a virus. Women above 21 get your regular pap smears every 3 years, and girls and boys above 9 or 11 years, please get your vaccination done. Okay, this is the introduction for cervical cancer, which message should go to everybody. Now, in cervical cancer, which has not spread, it is, you can call it stage 2, 3, and 4A cervical cancer. We give chemotherapy plus radiation. Today, adding in immunotherapy by name pembrolizumab again to chemoradiation has improved the results. So, pembrolizumab with chemoradiation is an option for patients. If patients cannot afford, chemoradiation is the choice. But if you can afford, add pembrolizumab. The same scheme, you buy 5 injections, rest 12 are free. That's number one. Number two, sometimes what happens is cervical cancer may be not spread to major organs, but it spreads to lymph nodes in such areas where giving radiation to that high lymph nodes can give a lot of toxicity, like bowel toxicity, bladder toxicity. So there what we do is we give weekly chemotherapy for 6 weeks, followed by chemoradiation. That has helped to downsize the tumor, limit the field of radiation, reduce the side effect of radiation, and improve the outcome. So today, in locally advanced cervical cancer, where you're worried about radiation toxicity, induction chemotherapy weekly for 6 weeks, followed by chemoradiation, is an option. The second option is chemoradiation plus immunotherapy. So these are the two main advancements in 2024 with regard to cervical cancer.
So do you think pembrolizumab is the star molecule of 2024? Because it's come up in a big way and you have been
So not only
highlighting it for various cancers.
so Pembro today is actually a star molecule. I think it is one of the most prescribed oncology molecules on the planet. Even if you look at the sales, if you look at the numbers, and they look at the indications, head and neck go down. Head and neck cancer, you use pembrolizumab. Lung cancer, you use pembrolizumab. Okay. Then esophagus, you use pembro. Stomach, you use pembro. Colon, if you are MSI high, you use pembro. Liver, you use atezolizumab. Pembrolizumab is literally used. Pembrolizumab is literally used in every setting.
And sir, any other immunotherapy molecules which have come up in a big way in 2024 besides pembro?
Durvalumab we spoke about, maintenance small and non-small cell. Atezolizumab has been there in HCC for quite some time now. Then we talk about avelumab in bladder cancer, which has been there earlier also. Nothing specific to 24. But these are the molecules you are juggling with. There's a drug called dostarlimab. Like pembro, it is used in MSI high colon cancers. Now, just to give you a brief, see, colon cancer stage 4 means you give chemotherapy. We have discussed that earlier. And you may add targeted therapy. 4 to 6% of colon cancers have something called MSI high. That's a genetic problem. You do it on the tumor. The test is done on the tumor. If the tumor is MSI high, you can avoid chemotherapy. Those patients are put on double immunotherapy called nivolumab and ipilimumab or pembrolizumab alone. That is, if you're MSI high, metastatic colon cancer, you don't need chemo, you are put on immunotherapy, either pembro or nivo-ipi. Got it? Hello?
Okay. Yes, sir, we got it.
Yeah.
I
So,
think there must be some technical glitch. So, sir, you can continue. We can crop it, sir. Please continue.
so that's the way it is. So MSA high, what we should understand is, our patients should understand is, any solid tumor which is stage 4, do MSI testing and tumor mutation burden testing, which is done on the tumor. If you are MSI high or TMB, tumor mutation burden high, you qualify for immunotherapy. The response rates are much higher and immunotherapy works much better than chemotherapy in these patients.
So, sir, besides immunotherapy molecules, any other molecule which has highlighted your 2024 for cancer patients? Any of the cancer patients?
See, all the hi-fi things which we talk, but still, I think the bottom line would be your traditional chemotherapy drugs will take care of your day most times. More importantly, I think what our patients should or people should understand in 2024 is prevention is more important than getting treated. So don't smoke, don't drink, take your vaccine, get your pap smears, get your mammos, okay? Get your sigmoidoscopy maybe once in 5 years or 10 years. Simple things. Stop taking tobacco in the form of betel nut, pan masala, gutka, etc. Avoid all these types of cancers and don't even come to the hospital for treatment. Because obviously you should not be having any kind of disease. So more
Correct.
than all the immunotherapy we talk about, that's all fancy, that is good for the session. But at least in 2024, the message should go out that no smoking, no tobacco, no alcohol, vaccination for hepatitis B, vaccination for cervical cancer, PAP and mammograms on a regular basis.
Okay, sir. And so, do you think cancer treatment has become more accessible for patients in 2024?
Definitely. No doubts. India is one of the best places to get cancer treatment. Go to US today or go to Finland. We talk about all those Scandinavian nations. We talk about UK. The NHS is under so much stress today. They don't have doctors, they don't have nurses. Patients having their appointment 6 months later, 4 months later. Here, now if a patient wants an appointment, you can get it in another half an hour or 1 hour. If not here, in another hospital. So access to care is no doubt about it. And in all tier 2 cities also. Now look at Karimnagar, Nizamabad, Warangal, Rajahmundry, wherever you want, you just name it. You have medical oncologists there, you have surgical oncologists there. This was not there earlier, right? And diagnostic centers, imagine the MRI, CT, SPECTs, you have it in every nook and corner. You have home people who come and do home blood tests for you. You don't even need to go to hospital. What more do you want? We have luxury of everything in India. And the price we pay is actually not very much also. So this pembrolizumab, 2 lakhs per cycle for 5 cycles, okay? 10 lakhs. And the rest of the cycles are all free. If you take the same pembrolizumab in US, you pay 8 to 10 lakhs per cycle. Okay, you may be insured, but nobody's doing it for free, right? You pay a premium.
Correct,
Okay, you
sir.
don't have any such schemes. You don't have any such schemes. None of these schemes. Yes, again, somebody may say if you look at purchasing power parity, our GDP is low, our per capita GDP is low, so 2 lakhs for us is a big amount. But in US also, there are a lot of people on the street, people who can't afford, lower middle income people. Not everybody has big houses or they can afford big treatment. So every country has its challenges. Our country has its own challenges, but I think still access to healthcare is very easy in India. And with Arogyasri and PM Jandhan and all that in most of the government hospitals, it's very nice.
So when we talk about cancer, we usually focus on adult patients. But are there any advancements which have happened in pediatric cancers or for pediatric patients?
So that I'm sorry, I am not a pediatric cancer guy. So I'm not qualified to answer on that, honestly. Definitely something would have happened in that domain, but I am not a pediatrics person, so I don't think I should comment on that. Sorry.
Sir, how has mental health of your cancer patients, are they getting any support for the mental health to maintain the mental health or to get the emotional and the social support that they need for surviving?
So that's a very valid point. See, most of our patients, right, the family is the biggest source. In our country, still, we are all a very closely knit society, unlike the West. So here, your daughter, son-in-law, daughter-in-law, grandson, your sister, your first cousin, somebody all will be pitching in for your treatment. So that way you have, and your friend circle. So that way we are blessed. Plus, now if you ask me personally, I would take up most of the counseling. The bulk, more than 99% of the counseling is done by me. I sit with my patients, I explain them, I tell the family what to expect, tell the patients what to expect, side effects, treatment, long-term things, diet, nutrition, activities, where they can go, where they cannot go, weddings, festivals, temples, society gatherings, so on and so forth. Regarding hair, regarding nails, regarding makeup, whatever you may ask, regarding having a second child. Okay. So you need to have a very close bond with your patient, very close bond with your family, with your patient's family. Document everything, communicate everything, be very transparent, and involve everybody in the family, at least the most important people, because only when they are involved, right, the patient also feels empowered. So it's not that difficult actually.
Okay, sir. And so, like in 2024, like ChatGPT and AI has come up in a huge way. Do you think it has impacted anything along your side as well, like in the medical field or in the field of oncology, in any way?
It will impact, but it will place a doctor placing his hand on the pulse of a patient. That is a very simple way I will put it. Whatever people may say, ChatGPT cannot do that. And even today, like our teachers used to say, the hallmark of a good clinician is good clinical medicine. Touch your patient, feel your patient, touch the pulse, look at the patient. When the patient walks into your room, the look of the patient should tell you, give you half the diagnosis. That no ChatGPT or AI will tell you. So that way, it can never replace our job. It is only complementary. And we should also give it the respect it deserves and not give it too much respect or not look down upon it. Or in the sense, we should be, what do you say, abreast with what is going on. You cannot say, no, I don't care about ChatGPT and go on in 2025 or 2035. You should know what little you have to know, but it cannot replace, because at the end of the day, my patient is not going to talk to a robot or to a system to get info. It needs a soothing hand and the comfort of a physician or a nurse to tell him or her that you are getting well. That no ChatGPT can do.
Okay, so I think that was a very well explanation which you have given, especially in terms for like AI and ChatGPT. So, what would be your closing message for all of your cancer patients and the caregivers, along with the family members who are involved with them?
Very simple again, beating around the bush again and again. Stay healthy, stay happy, mental health, physical health, emotional health, and spiritual health. All these are extremely important. Stay healthy, have a safe. I hope all of our patients, their families, and whoever is listening to us had a good 2024. And we wish them a healthy 2025. And we'll see them in 2025 with a lot more things regarding cancer.
Okay, sir. Thank you for this live session. And we hope to see you next year as well, sir.
Thank you so much. Pleasure. Thank you.
Thank you, sir.
Bye.